So now we're on to the pathology section of the chapter. While this is definitely where the bread and butter of the chapter lays, also, you should be forewarned that there are a lot of diseases listed here. Remember, this is a section to come back to a few times, to review the major diseases covered, and to look for key distinguishing features for each disease in order to keep them all straight. We'll try to present the key clinical scenarios relevant for most of these disease processes. I think once you really get into it, you'll notice there's a lot of commonalities that'll help you keep track of everything. The first disease we'll want to discuss is achondroplasia. Remember the concept of endochondral ossification we just discussed? This is what happens when it doesn't work. Normally patients put down a cartilage framework to help form the structure of their long bones before forming bone over the scaffold. In this case, a constitutive activation of FGFR3 inhibits the chondrocytes from proliferating. This means patients can't grow out their limbs and end up short. That said, remember, not all bones grow by endochondral ossification. Do you remember which bones, long or flat, don't? That's right, flat bones grow by membranous ossification. Because there's no problem with membranous ossification in these patients, they'll have a normal-sized head and trunk, though because their limbs are short, they will appear disproportionately large. There's a huge spectrum of osteochondrodysplasias, the family of diseases that includes achondroplasia, but this is one of the most common ones. So what will they ask you about this disease? Well, there are a couple high-yield concepts about achondroplasia you should know. First, this is one of only a few diseases that's associated with advanced paternal age as opposed to maternal age. Most patients develop the disease spontaneously, but if it's inherited, it's in an autosomal dominant pattern. Another important fact to know is that these patients will have normal lifespan and normal fertility. Osteoporosis is a really common disease, and as is the spirit of Step 1, common diseases are always well represented in the question banks. Osteoporosis is defined as a reduction of primarily trabecular bone. Despite normal bone mineralization and normal lab values, there are technically two different types of osteoporosis. Type 1 is postmenopausal, wherein decreased estrogen levels cause increased bone resorption. Type 2 is different, wherein slow but steady bone loss due to increased age leads to osteoporosis. Clinically, patients are assessed for osteoporosis using a DEXA scan. Their bone mass at multiple different sites is measured using the scan and compared against bone mass for young individuals. If their bone mass is less than 2.5 standard deviations from the mean, they're considered to be osteoporotic. If it's less than 1 standard deviation from the mean, they're considered to be osteopenic. There are many clinical signs of osteoporosis. The first one, and one of the most common ones, is a vertebral compression fracture, which clinically presents as acute or subacute back pain, sometimes after mild trauma, but often after no real trauma at all. Patients with osteoporosis can simply step off a curb, and the impact of putting their foot down that one time can cause a vertebral crush fracture. The classic clinical sign for this, and the one you'll see on tests, is point tenderness over the spine, usually along the thoracic spine. Often these won't fracture quickly, but rather will fracture gradually, leading to multiple subclinical vertebral fractures. These won't present as back pain, but rather loss of height and kyphosis. Just imagine a woman who's normally 5'2", who then gets her height measured at 4'10" at the doctor's office. A second clinical presentation is with fracture of long bones. Some common examples are a femoral neck fracture or a distal radius or Colles fracture. A classic question they like to ask about patients with osteoporosis is the meds that you can give them, not to treat the osteoporosis, but rather to treat other conditions in patients with pre-existing osteoporosis. Remember, old people fall down a lot. If they have osteoporosis and they fall down, they break bones, and in some cases they even die. If you give them something that can cause them to fall down more, they'll break more bones and have an even greater chance of death. So, you'll have an old patient with insomnia, and they'll give you 4 options. Say, zolpidem, a benzo, and diphenhydramine are the first 3. All of them would work, but they would all increase fall risk. The 4th option would be to screen for depression, not a first choice for all doctors, but definitely safe to do, and worth doing because depression in the elderly can present atypically. Remember to screen for depression. So if a patient actually does have osteoporosis, what would you think they would do for it? For one, they can prevent it in the first place by starting exercising and increasing calcium and vitamin D intake to improve peak bone mass. But even though you can't reverse time, you still have some other options. One is to use bisphosphonates, which are really commonly prescribed. Other options include selective estrogen receptor modulators, or SERMs. You can also use calcitonin, or pulsatile parathyroid hormone. We'll discuss the more common ones in the pharmacology section. Before we move to osteopetrosis, one final fact is you can't use drugs whose side effect profile includes loss of bone density. Can you name a common class of anti-inflammatory drugs that this includes? Glucocorticoids are the classic ones. You'll read in your pharm chapter that it also includes heparin. Osteopetrosis is an interesting disease and relates to an aspect of bone growth we haven't touched on in much detail yet. When you form bone, there's kind of a battle that goes on between osteoblasts and osteoclasts. Osteoblasts are forming bone quickly to ensure growth progresses steadily. Unfortunately, this often leads to bone being formed in a way that's a bit haphazard and not really refined into a good structure. Luckily, most people have osteoclasts to resorb and shape this haphazardly placed bone. This ensures it's mature and well organized before it's finished. Patients with osteopetrosis don't have normal osteoclast activity, unfortunately. This leads to them having thick, dense bones that are made of an immature substance. So even though you'd think they'd be extra thick and hence extra strong, they're also immature and actually prone to fracture. In normal, healthy bone, the center of bone is hollow enough for bone marrow to fill it. However, when bone growth is dysregulated, like in osteopetrosis, the marrow cavities actually get filled in. This leads to the most devastating problem of this disease, which is hematopoietic. There's anemia, thrombocytopenia, and neutropenia, all of which gets referred to as pancytopenia, which can predispose to infection. This leads to extramedullary hematopoiesis, which, as you'll recall from the heme chapter, refers to blood that is created outside of normal bone marrow. It does not, however, cause any changes in serum calcium, phosphate, ALP, or PTH, much like osteoporosis. The gene defect to recall for osteopetrosis is a genetic deficiency in carbonic anhydrase 2. The X-ray findings are classically noted as having Erlenmeyer flask bones that flare outwards. The clinical pearl you want to remember, the sort of physical exam sign that would make you think osteopetrosis, occurs because bone enlargement impinges on cranial nerves. This leads to palsies. Osteomalacia is a disease wherein bones not mineralized appropriately. Basically, this results in bones being softer than they should be. Osteomalacia, translated from Latin, means soft bones. It's caused by a deficiency in vitamin D. Vitamin D, as you might remember from the endocrine lectures, is an important regulator of calcium levels in the body. Because calcium is low, patients will have a reflex increase in parathyroid hormone, which will also decrease phosphate levels. Remember that PTH is the phosphate trashing hormone. If you're suspecting osteomalacia, these lab values would definitely confirm the diagnosis. The term rickets isn't much different from osteomalacia, except it refers more specifically to vitamin D deficiency in kids. Would you expect to see an increase in PTH in kids with rickets? Yeah, you would, because it's basically the same disease. Paget's disease is another really interesting disease, particularly because the cause remains unknown. Osteoblasts and osteoclasts in the body both function, but both work abnormally. This causes the bone to appear much different than it would otherwise. The appearance is not only at the macroscopic level, but also the microscopic level when looking at the architecture of bone histologically. The current thinking is that a viral illness may play a part in the etiology, but it's still not confirmed. The classic lab value that's abnormal is an increase in ALK-Phos, a fact that you might see on your boards. With Paget's disease, there are two things you should pay attention to. You should know the key catchphrases that will make the diagnosis, and how the disease will kill you. So the first catchphrase, mosaic bone pattern, on macroscopic appearance and even on imaging, is a giveaway. Long bone chalk stick fractures are also common. Imagine the way chalk breaks, with a straight line across it axially. Healthy bone doesn't do that because it's designed to have a lot of resilience in that direction, but for patients with Paget's, it's much easier to break the bone. And how will it kill you? There's at least two ways it can kill you. The first is an arteriovenous shunt, which can form through the bone and cause high-output heart failure, which, as you'll recall from the cardiovascular lecture, refers to heart failure in which the heart is able to pump a normal amount of blood, but that blood volume is not sufficient to meet body needs. It can also lead to osteosarcoma as a result of disordered bone growth. The classical clinical vignette will likely have an older male with increasing hat size and also possible hearing loss because of narrowing of the auditory foramen. While the latter could be similar to osteopetrosis, the labs, age group of patients, and additional clinical findings all should help you differentiate the two. If the last 5 diseases that we've discussed so far are causing you a bit of trouble, don't be surprised. They definitely sound similar and have some overlapping features. Hopefully what we're going to do here is give you some pertinent lab values that'll help you wean down a differential that you're developing as you read through a clinical scenario. First of all, one of these diseases should have no abnormal lab values at all. Do you remember which one this is? Osteoporosis. Similarly, Paget's disease has only one lab abnormality, and that's an increase in ALK-Phos. Remember, these are not diseases that are caused by inappropriate hormone regulation or minerals. They're simply inherited or acquired defects in bone architecture. The remaining diseases are actually defects in bone mineral metabolism. In osteomalacia and rickets, patients have a decrease of what vitamin? That's right, vitamin D, which causes them to have low levels of calcium. This triggers increased parathyroid hormone levels to bring calcium levels up, but in doing so, this can drop phosphate levels. Osteitis fibrosa cystica is the name of the bone disease that accompanies hyperparathyroidism, as you'll remember from the endocrine lecture. Here, you'd expect that your initial lab value, PTH levels, will be elevated because that's the basis of the disease. This in turn causes an inappropriate increase in levels of calcium and a loss of phosphate. You'll also see an increase in alk phos. In patients with polyostotic fibrous dysplasia, the main pathology is that bone is actually replaced with fibroblasts, collagen, and some irregular bony trabeculations. As the name implies, it's an abnormal fibrous growth in many bones in the body. There's a type of polyostotic fibrous dysplasia that may be very boards relevant, and that's called McCune-Albright syndrome. As in any syndrome, there are a constellation of symptoms you'd expect to find in these patients, as we've already discussed. The first is polyostotic fibrous dysplasia, but notably it'll be multiple bones in the body on only one side of the body. The patients will also have characteristic skin lesions on that same affected side. Do you remember from the endocrine lecture what these spots are called? In addition to being called cafe au lait spots, they're also called coast of Maine spots. The final component of the syndrome is an endocrine abnormality. The classic one you'll hear about is precocious puberty. It's a really interesting presentation, actually. Here you can actually see loss of trabecular bone in the diaphysis of the tibia, and here we have a picture of the classic cafe au lait spots. Here we're going to discuss primary bone tumors, which isn't an incredibly high-yield topic. There are a couple we'll point out as being fairly important, though. Let's turn our attention first on the benign primary bone tumors. There are two that have very classic presentations. Giant cell tumors are the first high-yield tumor in this group. They occur in the epiphyses of long bones, and significantly they usually occur in patients 20 to 40 years of age, which is one of the distinguishing characteristics, as most other tumors in this group tend to be in a younger population. They're locally aggressive and often occur in the distal femur. Classically, X-rays will show the double bubble or soap bubble appearance, and histologically they'll show spindle-shaped cells with multinucleated giant cells. One more classic fact to know about giant cell tumors is that they're more likely to appear in females. The next tumor we'll discuss is slightly lower yield, but has a couple characteristics that should make it easy to recognize if it shows up on the boards. Osteochondroma, which from its name indicates it's composed of both bone and cartilage, is actually the most common benign bone tumor and often seen as a piece of mature bone with a cartilage cap in younger males. It's actually the most common benign bone tumor, and you often see it as a piece of mature bone with a cartilage cap in younger males. It commonly happens in the metaphysis of bones, growing out of bones and presenting as an exostosis. Another thing to note is that it can malignantly transform into a chondrosarcoma on rare occasions. Now we'll move to the malignant tumors of the bone. There are a few you'll be expected to know. There are technically 4 different malignant neoplasms, but only 3 will be discussed here. The fourth one, multiple myeloma, is actually the most common, but because it's related to B-cell physiology, we'll discuss it in the hem-onc lectures. The second most common malignant bone tumor is osteosarcoma, also known as osteogenic sarcoma. It usually occurs in males 10 to 20 years of age. Like the osteochondromas, osteosarcomas are normally found in the metaphysis of long bones. All of these details that we just mentioned may help confirm your diagnosis, but the reason you should think about osteosarcomas in the first place is because of these 2 ideas. A, what they look like on X-ray, and B, predisposing factors. Classically on X-ray, osteosarcomas are described as having a Codman's triangle appearance, or as a sunburst pattern. These terms radiographically describe what's happening pathologically in the bone. The tumor cells are growing underneath the periosteum of the bone so fast that the periosteum is being lifted off its normal plane of growth. This creates the triangle, or sunburst, that so classically describes osteosarcomas. The second thing you'll want to remember for this high-yield tumor is the predisposing factors for the cancer. The list is pretty long, but it's worth remembering. It includes Paget's disease of the bone infarcts, radiation, and familial retinoblastoma. Do you remember from the Path chapter what gene's commonly lost in retinoblastoma that's also frequently lost in osteosarcoma? That's right, the gene is RB1. With the first 3, you can imagine reasons for bone to be damaged and more prone to dysplastic change as a result. The second malignant tumor is Ewing's sarcoma. It's a type of tumor that's called a small blue cell tumor, a family of tumors that includes neuroblastoma, medulloblastoma, retinoblastoma, and Wilms tumor. Like all the others in the family, Ewing's sarcoma is very aggressive and presents often with early metastasis. However, it does respond well to chemotherapy, which is life-saving for patients. It can happen in a lot of different bones, usually in the diaphysis of long bones, but also in the pelvis, scapula, and ribs. There are 2 classic aspects to remember. The first is that it is a classic onion skin appearance. You can remember this with a memory aid, Ewing's and onion rings. It rhymes. The other important thing you'll want to remember is that it occurs as a result of an 11 to 22 chromosome translocation. There aren't any other malignancies on this page with similar translocation, but in the heme chapter, you'll see at least 3 more, so you'll want to keep this straight. If you're into basketball, 11 plus 22 equals 33, Patrick Ewing's jersey number. I also like to remember that the chromosomes are just multiples of 11, and Ewing's and 11 start with the letter E. The final tumor you'll want to remember is chondrosarcoma. We discussed it a moment ago, as it can result from a benign osteochondroma, but at times it can also occur as a primary tumor. You mostly see it in older men, as the transition from benign to malignant often takes a long time in bone. It occurs in a wide variety of bones, usually avoiding the distal extremities and skull. The classic appearance you'll hear about this tumor having is of an expansile glistening mass from within the medullary cavity.